5 session, the Cardiac Surgery Intervention and Morphology Workshop of APCIS 2022. I am Jeong-Wook, pediatric cardiologist at Busan Sejong Hospital. I would like to moderate this session in English and Korean. This session is designed to introduce hands-on training of surgery and cardiovascular intervention and autopsy specimen and 3D printing correlated of heart disease. 안녕하십니까. C세션을 소개합니다. C세션은 수술과 인터벤션을 3D 프린팅 심장을 통해서 보여드리고 다양한 질환의 부검 심장과 3D 프린트 심장을 보여드리는 시간입니다. So, as the part of this program, I would like to invite Professor Tae-Gook Chun and Chang-Ha Lee to explain what you would like to do today.
As a young surgeon, it's very difficult to have a chance to the scanning operation. Maybe today evening, maybe it's a great chance to practice the scanning procedure.
So actually today we are going to the anatomy repair using this cc-TGA model. So I think it'll take about 2 hours maybe, right? So we'll start Dr. Jang. Yeah.
Let the surgery team show you surgical procedure process. Please switch to the screen at the surgery teams.
Actually, for the scanning procedure, is very important to make actual septal flap. But in TGA patient, usually the septum is very small. Also, in corrected TGA, the septum is very small, so sometimes we need additional tissues. But in this patient have a big coronary sinus because of the left SVC. So we are utilizing the coronary artery tissue as a reconstruction of scanning pathway. So more easier than other patients.
So.
We need to go to this one. So.
Yeah.
Professor Tae-Gook Chun, please explain the procedure doing now, and summarize that, please.
This is a flap of atrial septum. So this is a pulmonary vein is here. So now we are doing the reconstruction of systemic pathway. So atrial flap should be sutured to in front of pulmonary veins. Okay. Now we are making posterior wall for systemic venous blood pathway.
Now surgeons are doing scanning procedure. That is we call the first layer formation. That means the isolation of the pulmonary vein. Right?
Yeah.
Yep.
Yeah. Thank you.
Thank you for your explanation. So I introduced Dr. Professor Chun-Soo Park. So what do you do now?
We just finished scanning procedure, and then we are planned to aortic translocation, even though I don't like the aortic translocation procedure.
So have you experienced that kind of surgery?
Oh, it's my first time.
It's your first time. How about you, these procedures?
Yeah, he told me just a minute earlier. He told me that I can do scanning procedure easily.
Is it helpful for you, your late career? Is it helpful demonstration? How about?
I think so.
You think so?
And yeah, maybe Sang-Won thinks so, but he is very sensitive now, so I can talk to him.
The most of participants enjoy this session, so we will move next table. Is another specimen. So there is a Professor Hangi Park. So what is this? What is specimen?
It's a congenital corrected TGA, so we are performing the root translocation, and Dr. Lee, Chang-Ha Lee is harvesting the coronary artery buttons.
So explain the procedures.
Yeah. So now I'm now harvesting coronary artery, and then harvest also aortic root. Yeah. No, it's okay.
Is it enjoy the session? Is it helpful for you?
Yeah, please.
I'm so sorry.
So-Ick Jang from Sejong General Hospital, and Dr. Worakan, very famous interventionist from Thailand. We will perform the Pulsta valve implantation.
Yes.
Okay, you can start.
Yeah, so maybe if you can introduce your valve a bit. This is Pulsta valve, right? No, if you can hold the wire a bit.
Yeah, hold the wire. Yeah.
Yeah,
Okay.
so now you can see it is tracking.
저거 잡는 거. Okay.
Yeah, so like that.
Yeah,
Okay. So now the valve is in place. Normally, you're going to deploy the valve a little bit distal and come back, right?
Yeah, actually,
Okay.
which is better? I think usually the balloon expandable stent system, we can deploy the narrowest diameter, I mean the choke point, but the self-expandable system, we can play the distal and drag the proximal state.
Yeah.
So.
Okay. Now, So-Ick will try to deploy the valve slowly.
Yeah.
So in general, Dr. So-Ick will clockwise rotating,
Yeah.
and if you can show here, then now the valve is opening slowly. Here.
Okay, slightly open.
Yeah. Now open more.
Yeah, open more.
Yeah. Okay.
Yeah, almost done. Yeah, because
And after that,
Yeah.
do you want me to come back a bit more, or do you want to open more?
it's full open state. So if we valve system drag the ampere level, the valve full flare state, I think.
I see. Then we should open more, right?
Yeah.
Yeah. You can see that Dr. So-Ick is pushing the Y, and then by pushing the Y, it makes the system coming back automatically. Okay.
Yep.
Yeah. Yeah. So that is the place, right?
Yep.
Then we can open more here.
I think the valve is slightly distal.
Distal?
Too much proximal,
Okay.
I think. Yeah.
Proximal. Then we can advancing a bit.
Okay. Okay. Yeah.
Okay.
Yeah.
All right. Okay. Now you will open more.
Open more. Yeah.
Okay.
I think the level is not bad, so we can total flare.
Yeah,
right?
I think so. So normally the operator will check the position by the angio, quick angiogram. And now you can see Dr. So-Ick is opening the valve more and more and more, and now it's almost ready to release in the next few seconds. Yeah. Okay.
Okay. Full flare state, I think, but I think there are some hook block issues there.
So we actively perform 3 teams of the performance, and then we move to intervention team. So we have to proceed the VSD intervention. So Dr. Worakan and So-Ick Jang, explanation.
Just to share the heart specimen, again, orientation is like this. Okay, so this is the right ventricle, and this is the left ventricle is like that. Right, it will look like this. Okay.
It's much
so
better,
again,
I
this
think.
is the mitral valve. Okay.
Yeah.
And this is the aortic valve. And so one of the leaflets is here, which is non-choric cast. Okay. And then this is the defect, as you can see here, right? So it means that somehow this valve is slightly prolapsing, and also somehow it's partially cover the hole here. Okay, so from this side, you can see the entry very clearly. But I show you again from the other side, I mean the right ventricle. You cannot see it. And that is because the tricuspid valve is, covering the defect. And in some particular case, it will look like the aneurysmal type defect.
Right.
And maybe this one is the exit, but not very clear. You can see it. Okay, so this is the typical finding of the perimembranous VSD. Which on the left side, this is not a perfect device in relation to this defect, but just to share with you that the device, somehow, if there's no distance between the defect and the device, the defect and the aortic valve, the device partly may touch the aortic valve and may cause aortic valve injury. And also the disc on the left side somehow may touch the conduction system and cause a heart block or left bundle branch block on the left side. Okay? And on the right side, like that. Oops, hang on. Okay. Yeah. If you remember the the heart specimen, around this part is actually will be the tricuspid valve.
Actually, there's tricuspid valve portion.
So tricuspid valve, septal leaflet. So this may cause the injury or disturbances of the tricuspid valve function as well. So some of the patient may have like tricuspid regurgitation. So in general, when you put the device in, we need to we need to pay attention at least a couple of things. First one is touching of the device to the aortic valve. Second, the touching of the device to the conduction system. The third is touching of the device to the tricuspid valve. And last but not least, you can see in small child or small babies, when you put the device here, you may have an issue of the left ventricular outflow tract obstruction by the device, right? So these are the things that by the angio and echo, you need to make sure before you release the device.
I'm a pediatric cardiac surgeon working at Seoul St. Mary's Hospital.
I'm Dr. Jae-Young Lee from the Catholic University of Korea. I'm a pediatric cardiologist.
Okay, so in this session we will show you various kinds of 3D printed heart models of congenital heart disease. And the next model is also tetralogy of the 5-month-old baby. You can see the right atrium, have coarsely trabeculated right ventricle, and main pulmonary artery and branch pulmonary artery. This patient had a relatively sizable, good pulmonary valve annulus. Okay, I will show the hollow model of this patient. Can you see this? Okay. You can see through the cut RV into the right ventricular space. This is a tricuspid valve, and you can see the overriding aortic valve overriding the ventricular septal.
This is a 3D printed model from 18 months of age. First of all, we see the surface anatomy of this model. This is SVC, this is RA. We cannot see in this model RA appendage. So left side we can see 2 RA appendage. This is left atrial appendage. This is right atrial appendage, so-called juxtaposition of atrial appendage. we can see two ventricles. This is actually an internal morphology. This ventricle has very coarse trabeculations, and this is relatively fine trabeculations. So we can say this is morphological left ventricle, and this is the right ventricle. There are two great vessels. This right-sided great vessel is aorta, give rise to systemic arteries, arise from morphological right ventricle. Again, this big vessel, pulmonary trunk, also arises from the right ventricle. So this is a typical type of double outlet ventricle. And let me see internal morphology of this patient. So,
줌을 좀.
good. Okay, this is the tricuspid valve, and this is actually aortic valve, and far anterior, this is the pulmonary valve. Two great vessels arise from this right-sided morphological right ventricle, and we can see here large VSD and aorta and pulmonary valve. Actually, large VSD is far from two great vessels, and there is some distance from this VSD and aortic valve annulus. So actually the VSD is quite remote from the two great vessels, but more committed to aortic valve. So hemodynamically, this patient has VSD type double outlet right ventricle. And again, we see the left LV cavity. This is the mitral valve. So we cannot see aortic valve here. Very large VSD here is only afro tract of the left ventricle. Okay.
So we did arch repair and connected the pulmonary trunk to the reconstructed aortic arch. So this is a kind of a node type operation. And for the pulmonary blood flow, we connected the pulmonary artery with RV using a 6 millimeter sized Gore-Tex ringed graft. So this is RV PA conduit type node procedure. This patient had also mitral valve atresia and double outlet right ventricle. For brief history, this patient had severe coarctation of the aorta and restrictive atrial septum. So this patient underwent coarctation repair and atrial septectomy and pulmonary artery banding to control excessive pulmonary blood flow during the neonatal period. And then around at the age of 6 months, this patient had underwent bidirectional cable pulmonary anastomosis, and this is the post-operative model. This is right atrium, and this large ventricle is morphologic right ventricle. And you can see the aorta is connected to right ventricle, and there's no pulmonary trunk because maybe I transected it at the time of BCPS. Looking back side, you can see the rudimentary left ventricle in the posterior aspect of the dominant right ventricle. And the aortic arch is quite good because I did a coarctation repair during the neonatal period. And you can see the right-sided SVC is connected to the pulmonary artery system. This is right pulmonary artery, and this is the left pulmonary artery. So in this way, the blood flow from the upper body is directly flowed directly through the pulmonary circulation without entering the single ventricle, because the single ventricle should pump through the systemic circulation. So this is the postoperative model of bidirectional cardiopulmonary shunt. And this is a model from the same patient, and one of my favorite model. This patient had a Fontan operation at around 2 years of age. You can see this a Gore-Tex graft, maybe 8 millimeter in diameter, connected from the IVC to the right pulmonary artery. Looking back, you can see the SVC and IVC is both connected to pulmonary arterial system. So in this way, the whole systemic venous blood now flow directly through the pulmonary arterial circulation without entering the single ventricle. So this is completion of long journey from neonate to the Fontan operation.
So finally, this session is over. So I'm so honored and happy to be a moderator in this session. So this experience is very wonderful experience. I'm thankful for all teachers of the free team of performance. Thank you for your guys. Thank you. And
Okay. I think this is well, nowadays we can join virtually, and with the model that the team here is preparing, I think it's one of a kind. I personally learned a lot from this model. So thank you for preparing this for everyone. And also thanks for having me.
Let me introduce some contributor of this session. First of all, Professor Cheul and Jeong from Catholic University. These collections are very great big collection of congenital heart disease. And please join. Through the 3D printed model and also some specimen to introduce the pulmonary valve PPVI, percutaneous pulmonary valve implantation procedure from the beginning to the final deployment of the case, and also the cocoon device for VSD closure is introduced in the 3D printed model as well as the autopsy heart models. And finally, the surgical simulation is still going on.
The operation is not finished.
Actually, cc-TGA VSD operation needs cardiopulmonary bypass time more than 300 minutes, so they need time more than.
So it's usual for real patient, and also this educational simulated surgery. It takes more time, and Professor Gook is teaching the guest surgeon.
Actually, I'm not teaching. I'm just assistant. He's doing very well. Yeah, he's an excellent surgeon. So, actually, I also enjoyed this session very much. Actually, the material is very good. Very, very similar with the. It's very good for the practice. So, thank you very much.
So we also appreciate Professor Yu Shi-jun in Canada Hospital for Sick Children to providing this kind of technology in collaboration with company. It's a Korean company to producing this silicon model for cases. Thanks to Professor Dr. Park Jin-sik and and Sejong Hospital and Foundation contributed a lot to this activity and so on.
thank you. So as a beginner, this session is very, very helpful as us. So we want to continue this session next year and the next year too, or more than 10 years. So thank you for your attention and enjoy participate in this session. Thank you.